So next up is our Consultants Corner, and our case presenter will be Dr. Sklow. Our panel includes Dr. Trudel, Dr. Lowry, Dr. Goldberg, and Dr. Alavi. And just a reminder, afterwards we're going to have a break, I think from 10 to 10:30, and if you could just visit the vendors and just thank them for their support for this conference.
So we'll start off with a... We're going to go a little bit out of order here. I figured the first one was too complicated for the panel, so we'll start with the second. This is a 56-year-old male presented to the emergency room with a 5-day history of bilateral buttock swelling, pain, chills, and rigors. On exam, he had a tender bilateral fluctuant masses right greater than left. White count was 12. So you took him to the operating room, and you found bilateral issue-rectal abscesses with an internal opening in the posterior midline at the dentate. So we had a classic horseshoe abscess. What are the surgical options? Dr. Goldberg.
I would just put in a ceton and drain the lateral limbs of it and go home.
So, the posterior midline opening is visible during the first surgery, during the OR?
Yes.
Okay. Yeah, so I would drain laterally the lateral limbs. If there is a posterior midline opening, then try and put a ceton through that, as Dr. Goldberg said, and go home too. And wait.
I agree. I do just drain the lateral sides, although I think sometimes you have to open the whole thing up, but I wouldn't do that at the first stage.
Anyone want to do the Hanley procedure?
I think it's a procedure that we're going to stop doing.
Nobody wants to cut through the sphincter into the postanal space.
Yeah, no, not.
If it's a true intersphincteric abscess, but usually those are lateral.
Yeah, this is a deep postanal space abscess, classic horseshoe.
I think because of all the inflammation, I would be wary about doing that at the first go-around. I'd wait and let things cool down and then come back to fight a different day.
I agree. I think it's important actually to obviously drain the sepsis acutely, but after that you want to be able to image this and figure out exactly how much muscle is involved. And we're good at clinical impression in the operating room that this is only an intersphincteric port. We also make mistakes, and we can't always evaluate that. So discretion is the better part of valor. If you're cutting muscle and you're making that patient incontinent, you're not ahead of the game. You can always come back.
So I think, I agree with what everybody said, but I think this classic procedure is based on the belief that if you leave the puborectalis intact posteriorly, that the patient will be continent, and I do not believe that. And I think there's some data that that's not true.
It never looks like that in real life.
So you do incision drainage of the
Is that what you did?
Well, yes. No. What was done was the issue-rectal abscesses were drained and a ceton was placed in the posterior midline through a counter-incision 3 centimeters from the anus. Which is basically a modified Hanley procedure without cutting any muscle.
It's a staged Hanley. That's what I would call it.
Staged Hanley.
Right.
So that's kind of what it looks like. Now the actions aren't exactly working, so we're just going to have to bear with me. So counter incisions heal. You have now a posterior midline fistula, and you estimate about 40% of the sphincters involved. And that's kind of what it looks like on the right. So your options. Anyone want to get a transrectal ultrasound at this point?
Well, I just want to say that I've been vindicated in saying that we're not very good at deciding how much muscle is involved in this. Again, in my book, if it's more than 25% of the muscle, and probably less in women, that for me makes a huge difference in the way I'm going to approach this. So it's important to get the information.
Well, you estimate about 40% based on your finger.
Well, get the ultrasound, and you can put a number on that.
Absolutely.
The ultrasound that you get doesn't tell you that. It just says there's significant muscle involvement. That's how it was read out.
Is that it?
Yeah.
I'm surprised.
I may have altered that a little bit.
No, ultrasound, in Europe they'd get an MRI, but here they'd get an ultrasound.
So I would tell them that we're going to have to wait for a while before we do anything. I would say two things. One, wait, and then wait some more, as was mentioned. I forgot who mentioned it in their talks. And then two, I would warn the patient that because they have a complex fistula, that they're going to likely require a minimum of 1 or 2, but maybe more operations, just to be on the safe side.
How long are you going to wait?
Oh, I wait at least 2-3 months, if not longer.
So I use the ultrasound for that because I think the ultrasound is helpful in telling how much muscle there is involvement. But the other thing is that sometimes you see a big cavity along the track still that you might not appreciate depending on the patient's body habitus, but also you can see if the lateral extensions have really closed. And sometimes the wound's healed, but you're still seeing an extension. And I wait till that happens.
Not everyone has access to ultrasound, especially in today's day and age.
So I do an exam under anesthesia and be sure the tract wasn't wide and that the lateral extensions had closed.
So the lateral extensions are closed. You just have the posterior midline fistula. So anyone want to put a plug in that? Okay, what's the next step? Do we do a lift?
We got conned on the plugs. Forget about it.
Agree. I just threw that up there because it probably shouldn't even be up there.
Sorry. What I discuss with my patients is for a high fistula like this, just the way Dr. Goldberg was saying, we're balancing continence with cure of the fistula. We are going to put their continence at risk if we do anything that cuts the sphincter. So we're going to sphincter-sparing procedures. In my book, there's two. There's a lift procedure, and there's a rectal advancement flap. I don't believe in plugs. I don't believe in glue. I don't believe in any biologics that you put in there. I don't think the data, which is always very good when it comes out with a lot of hype, over time never holds up. So it's either a lift or a flap. I start with a lift. That's usually my first recommendation.
I do whatever she says.
Anyone want to do a cutting seton?
No, that would not be my first option. I would also do a lift. That would be probably the best data that's out there would be the lift. And then the flap if the lift fails.
So
I'm amazed at the data that comes out on cutting setons from other parts of the world. We gave it up, how long ago, Rob? 15 years ago? 30? It was about 15.
That's after Julio wrote that paper showing cutting setons have a high incidence of fecal incontinence.
Actually,
right. So a lift was performed, and the patient actually ended up with intersphincteric fistula and then had an intersphincteric fistulotomy and healed the fistula. We're going to change the scenario. So now you have bilateral ischial-rectal external openings with an internal opening in the posterior midline. So you have a complex fistula with 3 openings. You've got your seton in the posterior midline and your 2 ischial-rectal openings that didn't heal. Does that change anything? Or are you going to proceed the same way? Dr. Goldberg.
I would do the same thing. Obviously, the ultrasound is going to help you a lot. Might consider, when you get the ultrasound, they squirt a little hydrogen peroxide in there, so you're really getting a fistulogram as well as the ultrasound to evaluate the muscle. And then you better be suspicious of Crohn's disease, your favorite disease.
Well, you have 2 external openings in the right and left lateral that go to the posterior midline, and now you have your seton in the posterior midline.
Well, I mean, if you have a common channel going through the muscle, then you could still do the lift.
Right. Yes, that's exactly what you have. So that doesn't really change anything.
No, not for me.
I would like to see that. I mean, if the openings are there, my suspicion is that there is some granulation tissue and there's something deeper that hasn't healed. I would like that to be closed up before I'm starting to address the sphincter. Main reason being that right now you're doing a relatively clean procedure when you're doing an intersphincteric dissection, and if you got pus and granulation tissue just right next to that, I would worry about getting that infected and running a high risk of failure. So what I would do is I would open up those lateral areas. Sometimes you have to just open up widely, drain it widely, let it heal completely before I would attack the posterior opening.
I'm just going to be the voice of reason here. with these bilateral extensions, it's not uncommon to find a chronic abscess cavity in that posterior midline, which then really blows everything apart in terms of doing a lift or anything else, and you almost have to come back again. And that's why I tell the patients there is a chance that you may have just one operation, or if you have a really complex fistula, maybe multiple operations to try and get it corrected.
With what Judith said and Karim, but I think that I really want those lateral extensions healed, and it is, I think, for me, it's always discouraging to tell somebody I have to open up these tracks, but many times the patients then say, oh, why didn't you do that in the beginning? The thing just healed up once you did it, so.
Very good. All right, we're going to change gears a little bit. This is a 35-year-old female presented with a 10-year history of rectal bleeding. Colonoscopy showed a large villous polyp in the distal rectum extending to near the dentate line, occupying 80% of the circumference. The biopsy showed a sessile serrated polyp. So she had a TEM. It was a 5 by 5 centimeter polyp, 80% circumferential. The suture line extended to the dentate line, and the pathology showed a tubulovillous adenoma. 3 weeks postoperatively, she developed increasing rectal pain and fever. She had a copious purulent drainage from the vagina over the weekend that improved over 2 days. On exam in the office, she had dehiscence of the TEM suture line with an 8-millimeter defect in the rectovaginal septum. Her tissue soft. So you have a rectovaginal fistula after a TEM of a low-lying rectal polyp. What are the options? Dr. Goldberg. She's now 3 weeks post-op.
Better be conservative. I don't think I'd rush in there and do a heck of a lot at this point. She's not septic,
No, not now.
but she doesn't like the discharge coming out of her vagina.
It's not horrible. It's manageable, but she doesn't enjoy it.
Who does?
Wait.
Yes, I would wait too.
So the symptoms from any kind of rectovaginal fistula can go from it's a nuisance to it's incapacitating. And unfortunately, our recommendations when we deal with something like this tend to be we need to wait and let things settle down. Sometimes it takes a bit of selling with the patients, but this is a fresh, dehisced, infected wound, and I don't think that going back there early is going to be successful. So waiting is the best option, particularly if she's bothered, but not so much.
I would agree with that. I think that oftentimes we're asked whether they need to be diverted, and it's really just for symptoms. So if they have loose stool that you can't control and it's pouring out their vagina, then you might divert them for that reason. But for healing purposes, you just need to wait. As long as you're sure there's no cavity in the rectovaginal septum. If there's a cavity, then I have put a ceton in.
Well,
Is there a foreign body there? Is there a suture there?
No foreign body. So I didn't wait. Her tissue was soft, so I took her back to the operating room, and I did a primary repair of the fistula and repaired the TEM suture line dehiscence. As expected, it didn't work. The repair failed, so she had an 8-millimeter persistent rectovaginal fistula. Now, part of this is you're repairing scarred tissue, so it didn't work. Now what? Now we're going to wait, like we mentioned. The fistula decreased to about 5 to 6 millimeters after 3 months.
Send her to Ann Lowry's clinic.
Well, I would probably try to study it with an ultrasound to see how much muscle is remaining in the anterior position. Has she had any obstetrical injuries in the past? Nothing?
No.
So I would still get a pre-op assessment of her fistula tract and then plan on doing, if there is a sphincter defect, doing an overlapping sphincteroplasty. If not, then an advancement flap, depending on where the fistula tract is. Well, actually, maybe not an advancement flap. Maybe I would call Dr. Lowry for the Marty as well.
Remind me how old she is.
She's 35.
She's 35. All right. And your margins of resection were negative?
They were
with
negative.
Your TEM? All right. So Dr. Goldberg made an important, very quick comment in his presentation, and it said, not every fistula has to be operated on. just want to put that there. Again, based on symptoms, this is not something that is malignant disease or any issues, and she may be able to live with it. I'm not saying I'm recommending that. I'm saying that's one of the options, and it's worth it discussing it with the patient, considering the fact that she's already had 2 procedures. It's going to be more complicated, and she's going to see an expert, Dr. Lowry, to try to get some to get some tissue interposition to deal with this. Yeah, believe me, I send them all to Ann Lowry. But she's going to need some sort of tissue interposition. I think that's the next step.
What I tell people is, first of all, even though they've been told I'm the greatest thing since sliced bread, I do not have magic hands, and things don't always work in my hands. So I would get the ultrasound, assuming that there is no sphincter defect if she's not had obstetrical injury. It would depend on the exact location, and I would wait a total of 6 months. If it continues to shrink and it's small, and I agree with Judith that you want to be sure the patient doesn't want to live with it, although there are very few women who choose to live with it. And then you have to factor in there, since she's of childbearing age, does she want to live with it till she's had kids? I mean, this is a discussion that you have to have with patients about exactly where in their life they want to consider having this fixed. But if it's small and very distal, so in my mind that means near or within the anal canal, then after 6 months, I might try, and she doesn't smoke, I might try an advancement flap, and I would use the Cleveland Clinic approach. That was very short, horizontal, very horizontal, short flaps, and see if it would close. If it, and they need to be told, as everybody said, that the first time it frequently doesn't work. But then you'd have to, then it would depend if a miracle has happened, and this is within the anal canal and the muscle's intact, you could conceivably do a lift. I've seen it once, so these miracles don't come along. If it's above the anal canal and it's persistent, then I think you do have to think about a tissue interposition.
So it's at the dentate line, and her ultrasound shows no defect in her muscle.
Where is it in relation to the dentate line? Right at it?
It's at the dentate.
Maybe it's anterior. You might consider an anal flap skin and slide it up inside, anal-cutaneous flap.
We'll get to that in a minute.
Okay.
So you could, and if you think it's, the trouble is you've sort of messed with the dentate line.
I did.
So
that was the problem.
Exactly what that is in relationship to the anal canal is a little unclear.
So I did a flap, like you said, and unfortunately the flap consisted of scar tissue.
What
from the
kind of
previous
flap?
TEM, sliding rectal advancement flap. A partial thickness.
From above?
From above, and brought it down. But it consisted of scar tissue from the previous TEM, which doesn't have the greatest blood supply. So lo and behold, it failed. So now what? Divert, Martius, gracilis, coloanal pull-through.
Go from below. Take some skin from the perineum and slide it up there if it's that low.
How bad are her symptoms now? Worse than they were before?
A little worse than they were before. It's a little bigger.
But still manageable? Can
Yes.
you wait? Or
You can wait.
Okay. Yeah.
She's
I would
pretty
wait.
resilient.
Okay. Yeah. Clearly. I would wait at least 3 months, if not longer, and then I would really think about either a gracilis or a Martius. Probably a Martius to start with.
Diverted or undiverted?
Undiverted. She's
She's fine.
She's fine.
Although Rebecca Cannon, I think, did a paper, didn't she show that if your success is better with diversion?
For the gracilis, there was definitely better outcomes with a diversion, and I really don't think anybody, Rob should speak to this too, but I don't think people do that without diversion. But the Martius, the data is that it's equivalent. So when you did so I guess I would be thinking, when I did the flap, what did I really think about its relationship to the sphincter muscle? Because the one thing that could conceivably be done that wouldn't be a big deal is to try a lift. As I said, that essentially never happens. And then I would consider a Martius. A coloanal pull-through, which is done for rectovaginal fistulas, is a big deal, obviously, and has lots of other effects. And so I would be really slow to go there.
That was a distractor. I didn't think anyone would really do that. So she had a Martius flap repair after waiting 6 months, like Karim said. And it failed. Surprise, surprise. With a larger 1 centimeter defect now in the rectal vaginal septum. Now she's not really happy anymore.
Other than not being happy, how symptomatic is she?
Pretty symptomatic.
So I would divert her, obviously.
A centimeter's big.
Yeah,
And the tissue you've got there at this point in time, it's scar tissue, it's macerated tissue. I mean, it's got all sorts. This is not good stuff.
It's not
you
great
can work
stuff,
with.
no.
No, it's not great stuff. And you already have a Martius flap in there that hasn't survived somehow.
Right. So we've all agreed to divert her. So she had a laparoscopic ileostomy, and I redid her sliding flap. It was
You don't learn quickly, do you?
No, I'm a glutton for punishment. The flap failed, but her defect's now only 3 to 4 millimeters, and much smaller. And now it's been probably 6 months.
She doesn't have Crohn's disease, Brad?
No, this girl does not have Crohn's disease.
Could you mobilize some vaginal, just do it on the vaginal side and see if you could close it there? I don't know.
I suppose that's possible. I didn't think of that at the time.
That would not be unreasonable. I mean, it's going to be, anything you do in that plane is going to be hard now because you said a transperineal repair. But it wouldn't be unreasonable if it's small to try that while she's diverted. I do want to, there's a study out of France which just I think is interesting and relative to this, is that they looked at their experience of several hundred patients. And based on that experience, they developed this algorithm that is not, they have not then done the follow-up study to see if it works, but their algorithm now is after the first repair fails, divert, and then do a big operation. That it's just, you're just sort of fooling around and kidding yourself if you don't do that. Now, I don't know that that's generally accepted, but it's worth noting.
Probably in her, that may have been a good idea. I mean, we got there eventually. So now she's diverted. She has a smaller defect. Dr. Goldberg? Leave her with it? Ileostomy for life?
Possibly. I'm not sure you can, I mean, if you're going to go ahead and try to do a pull-through on it, something like a cutate operation or something and bring down some fresh tissue, she might be continent, but the results with that are 40% are okay.
Sorry, so the opening is in the same location, just above the dentate?
Yes, but smaller.
But
Just at the dentate.
Just at the dentate.
Yeah.
But this constantly moving dentate.
No, dentate hasn't moved. Same spot.
I mean, I guess I would try that horizontal mobilization, give that a shot so she's diverted. The other option would be, I mean, if the tissue, I would do an exam and wait at least 6 months, do an exam under anesthesia just to get a sense of what the tissues feel like. Because I think at this point you sort of have to be more conservative rather than super aggressive. She's diverted, you have time. As long as the stoma is not, she's not having a lot of issues with her stoma.
No issues.
Then I would wait. I would re-examine her in the OR just to get a good sense of the anatomy. I would probably get an MRI to see if there's anything else that you're missing. And then maybe a gracilis. At this point, she is diverted, bringing a different sort of tissue. I don't have any hope of it working, but.
So my concern is also the variable size of this fistula, which has gone from a few millimeters to centimeter to, and right now it's diverted. So I don't even know that I trust that it's 3-4 millimeters because it's not under any kind of pressure. I'm just voicing the concern.
So those of you who work with me know that I have drunk the Kool-Aid of the microbiome. So this is work based on John Alverdi in Chicago, who has done this work of proving that sometimes under physiologic stress, enteric bacteria can develop the ability to develop collagenase so they can break down tissue. And we have, and this is, these are small numbers of patients, but both mine and some fistulas that have been sent to me from other places, we've done this testing and found that they had very high collagenase activity in the bacteria, so you have to send it to John's lab in Chicago. And nothing works until you treat that bacteria. And then so far, I really need to knock on some true wood, so far if the bacteria are eradicated, then the next repair has worked. So I would consider that in her.
Well, Dr. Goldberg mentioned dermal advancement flap to bring better tissue into the anal canal, which is actually what I did. So I did a reduced sliding flap to pull better mucosa down after trimming some of the scar, and then advanced a VY dermal advancement flap 6 months after she was diverted. The fistula healed, and her ileostomy was taken down 3 months later. And seeing her back in the office, she would say maybe she occasionally has gas through the vagina, but she's not sure. She has really no symptoms, so I called it a win, and that was it. So I advanced tissue in the anal canal, and I brought better mucosa down to meet in the middle, and it worked. Good. So I think we'll end the session here for the break. Oh, question. It did. That was a full thickness excision, and after this horrendous complication, I'm very tenuous now in the anterior midline when I have one of these to be cautious because the vagina's right there.
Probably nobody really does, but so I do prep them. I give them a full bowel prep. I give them perioperative antibiotics, but I give them one dose like I would other surgical patients. I don't leave them on antibiotics. I counsel them very strongly about their bowel function because constipation's obviously bad, but diarrhea is worse. So I have found that people often, I tell them constipation's bad, so they start taking Rectal or X-Lax, and they have diarrhea, and that's worse. And it's done as an outpatient.
Dr. Goldberg.
Just a word about advancement flaps. If you look at the literature, the majority of advancement flaps that work are anterior. Because of the angle between the anal canal and the rectum, if you try to bring down an advancement flap to close a fistula posteriorly, you're going to have a tough time getting it down there with no tension. So it's got to come down there with no tension at all in order to work. And the ones that usually work are anterior.
And just a comment on the bowel prep. Do you think that once you bowel prep them, they're higher risk of getting constipated post-op or having diarrhea post-op because now they've been cleaned out and they're starting to slowly? Have you had any experience in that or had any patients that have developed?
Not that I've thought. Yes, of course, I've had both, but not that I've thought it was because of the bowel prep. Okay. The reason I do it is partly just because if I used to give them enemas, and then half the time you had watery stool down there in the field. And the other reason is that it's so hard to predict what their true bowel function was, whether they have this their colon's full of stool. Because some of those people that say they move their bowels every day, you did an x-ray and their colon's full. So but I don't have there's no data to support that.
Thank you.